I talk a lot, and my area of interest has been, for the last couple of years, medical professionals. I'm writing a textbook on that. We don't have any place in the country or in the world where we're teaching it at an undergraduate institution. I've been teaching it here at Rice for 4 years. So one of the things that I've been working on is to get that done. I'm working with a publisher. So I kind of wanted to expand my horizons today because I feel like, okay, I have a sense of that, so let me try to go in another avenue with you. I recently got board certified in lifestyle medicine. It's an emerging discipline, and I really want to just give you an overarching view. There's a lot of very interesting data points, but because it's so new and fresh, I just want you to get a sense and a taste of what this is about. So just a quick poll. Raise your hand if you agree with this statement. Smoking cigarettes does not cause cancer. Anybody still there? Okay, when did we decide as a world and as a country that this was a fact? An idea. What year? Approximately. What do you guys think? You know I'm going to call on people I know. What year? What do you think? 1980? Okay, that's a good guess. That's a good guess. Anybody else? What do you think?
76.
76? Good enough. Okay. So the point is that it's very recent. No matter what it is, it's very recent. And what does that mean? Before that time, whatever that time was, and it was actually 1953 when it was first released, but it's close, we lagged in how many decades it took us to get to where we are now, and I think we still have a long way to go. The point here is, what did we used to believe before then? What did we used to believe before then? So let's walk ourselves through this. These are cigarettes for treating asthma. 1800 to 1985, they were sold, marketed, they were out there. Here's some more. They continued. They continued for being treated, helping you. Here we go. Physicians were telling you this is less irritating. If you've got a sore throat, go get a cigarette. Help yourself. Dentists are recommending it. These are actual ads. Okay, these are actual ads. So this is actually a hospital bed, and if you can see here, I'm sorry about the granularity of this is a patient. These are obviously nurses, and they're selling cigarettes at the hospital bedside. This is not that long ago, okay? So we had Listerine available in cigarettes because, boy, you need to freshen your breath as you smoke. We all know that. And pregnant women. Is this horrific? This is not that long ago, guys. This is in your parents' and your grandparents' lifetime. Okay? This is the data and the science that was touted to give us that information that cigarettes somehow decrease your anxiety. Whether this is true or not is irrelevant because we know all the negative effects of it as well. But this is what was out there. Okay? Doctors are smoking Camel more than anything else. If you read all this stuff, they're actually talking about why you need to do this and how this is going to benefit you. And in fact, L&M filters are just what the doctor ordered, and this is a statement from a doctor about this will help you calm down and do better. Her singing coach advised her to do it. So I think everybody should be doing it. The kids were buying it for Christmas and the holidays for their family members. And they use kids to market this all the time. A lot of pulling at your, gut. Look at that cute baby. Here we go. Here's some more. Then they started marketing to children because that wasn't enough. My daughter's in marketing, by the way. I have no problem with marketing people, but I'm just telling you the trajectory where we're going so that I can get to the actual topic. And when things started coming to a head, this is actually 1953. So this was right before the government released that data saying that potentially there's an association between cigarette smoking and cancer, that they got really, really hard, the scientific evidence thing. So what happened? What happened with this, and where are we now? So then we've been able to actually look at the fact that if you actually put labels and warnings on it, that actually decreases people's use of tobacco. This is what we have. If you want to go buy cigarettes in Australia, you would have to look at this. Every time you open it, you're going to have this in front of you. It's pretty disgusting, right? So this is, what is that? Negative what is it called? When you do the opposite and you get behavior modification. You know what I'm talking about? What is that called? Where you try to get people, aversion therapy, whatever, something like that, right? So this is what they do. Look at what it looks like in UK and Australia. So you go to buy cigarettes. They're not glossy. And they did and paid a lot of money to do marketing analysis to see what would deter people from buying cigarettes. Why am I telling you all this, guys? Why have I wasted 2.5 minutes of my 30 minutes on this? I will answer the question. It's not seriously a question. This is where we are in the U.S. They struck down having graphic warnings in cigarettes. And again, they start trying to do it again. All hospitals in this country have been smoke-free since 1993. And they're trying to get these graphic warnings because we have not done such a good job as the other countries in decreasing our cigarette smoking. Okay? And we know that it's directly connected to cancer rates. So the fact that we haven't done that yet, what would be the cause of that? I'm trying to mitigate a potential word that's going to come out of your mouth. So what would be the cause of it? What would be the cause? Not conspiracy theory, right? I'm trying to get away from that term. I want you to be able to hear the rest of this without thinking that I'm talking conspiracy theory. Why would we not have this where we know? What is the reason? Sorry, I don't know your name. Emily. Oh, Emily. So tell me, what do you think the reason would be? Why haven't caught up with science and been able to do things that would protect our population and deter?
Maybe not everyone is educated about it.
But the government, it's regulations and policies. Why haven't we put them into effect?
Because cigarette companies don't want them.
So lobbying. Lobbying is one. And then the other side, what's the other extreme side? So lobbying is one point, and then the other point is we want our freedom to choose what we want to do. We don't want regulations in this country. So there's both extremes of that, right? So it could be either one or all of the above. Okay, so yes, absolutely. So here we go. It took so many years for the regulations to catch up. So here we go in 1950s. We're saying the first time cancer concerns came up. Then they started doing all these conferences. Then they started making all these regulations. And then there have been major settlements because they knew about it back here. But they were still not introducing that to people. Okay. So what am I talking to you about? Why am I doing this? Because the data I'm going to present for the next 23 minutes is not going to be intuitive. It's not going to be happy. But it may be something that you may have been presented if you were living and had attended this lecture in 1930s and 40s about cigarettes. If I came up to you in 1930 and you were there and I was here and I was telling you about the carcinogenic effect of cigarettes and tobacco, you'd be looking at me like, really? What's wrong with you? I smoke every morning, I smoke every night, my grandmother smoked, right? That would be the conversation. So, can you give me, please, I need a nod, an open mind to what I'm presenting to you? I would argue that I don't know the answers, but I'm presenting data that may be true. And I'm going to show you some of the evidence-based data around it. So we can have more conversations down the road and you can think about it on your own, right? That's the purpose of this talk. Got it? Are we good with that? No? No nodding over here. I got a nod. Are you okay with that? Yes? Okay, good. So lifestyle medicine is a new discipline. It's had board certification for 2 years. In medicine, every discipline that's established, internal medicine, cardiology, cardiovascular surgery, whatever it is, if you guys are intending on being a physician, they have to go through a process. And in the beginning, the process is that they want to get a significant number of people in the discipline, so they let you take a bunch of continuing medical educations, take a board certification exam, and then you build the discipline. I am one of those people that's building this discipline, okay? So I just want to let you know that I have a bias, but that's it. That's my disclosure. I have no financial arrangements or anything. I've actually paid a lot of money to be involved in this organization. So what lifestyle medicine basically is it's focusing on 6 areas to improve health. So it's about healthful eating, physical activity, managing stress, forming and maintaining relationships, improving your sleep, and cessation of tobacco. So what it is not integrative medicine, which integrative medicine is a combination of CAM and conventional medicine. Conventional medicine, we all know what it is. It's most of the MDs and DOs in this country. That is basically what we talk about when we say we go to our providers. CAM is usually not evidence-based, but there's components of it that may be evidence-based. Functional medicine is basically looking at a cellular or molecular level of causes of diseases. That is not lifestyle medicine. Mind-body medicine is the relaxation, hypnosis, meditation. They tend not to be based at this time in strong evidence and mainstream in most circles. Preventative medicine is basically more about population-based interventions like immunization screening. Okay. So what is it then? What does it do? It avoids fads and dogma. It is basically solidly based in evidence and data and research. It addresses the lifestyle-related causes of morbidity and mortality, and it's mainly about changing your focus. So if I told you right now, anybody in here have family or friends that have had cancer? So we would say half the people, family, friends, neighbors, loved ones. If I told you that a certain percentage of what may have been part of the cause or the potential future prevention of the cancer can be mitigated by lifestyle changes, would you be interested in that conversation? Okay, that's what we're talking about. Don't listen for yourself, listen with an open ear for them, okay? That's what we're talking about. We're talking about arresting and reversing most chronic diseases. My bias, 25 years of clinical practice as a physician. We tend to, most of the time, treat side effects of the medications we prescribe. Okay? 70% of people in this country are currently taking medications, prescription medications. Let me tell you, all I do all day long is see people that come in with depression, with other symptoms based on their reaction to a medication they're getting to treat a disorder that has other non-medication treatments available that have been studied and have shown very good rates of success. Why are we not prescribing them? Why are we first giving a pill? Why do you go to your doctor and get a pill for every last thing that you are going in there for? Would patients actually listen to physicians if they said, oh, I know, and the data shows that if you do blah, 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 and blah, then you could potentially decrease the risk of having this disorder anymore and actually reverse that. Would you do it? Okay. Can I tell you something? Physicians don't know this. This is why this discipline is being developed. We don't get trained on preventing with non-medication causes. Okay? I'm giving you a somber point, but the light, the rainbow, what is it? The light at the end of the tunnel is that we now have it. Okay? So why now? There's a convergence of forces, obviously. We're documenting it better. We have some very interesting thought leaders that are doing some interesting studies. I can tell you that my brother, cardiovascular surgeon in the Mass General Harvard system, really poo-pooed this stuff. So first of all, he poo-poos everything I do, okay? So I'm sorry, is there a better technical term for poo-poo? I don't know what's a better way. He devalues everything I do. He's a surgeon, he's based in science. I'm a shrink. I do soft skill stuff, right? Okay. So when I sit here and talk to him about interventions and preventative and lifestyle changes, he says, really, sis? It's so funny, 3 years ago he shifted because the data is so compelling. He opens hearts for a living and was able to see reversal in atherosclerotic disease and cardiovascular disease in patients by lifestyle changes alone, okay? Most of the thought leaders and the people in the Mayo Clinic, Harvard system, they have all developed courses around this in the medical schools. There's a discipline and a residency that's being developed right now. This is it. This is cutting edge. Okay, so I'm just trying to give you a little hook here so we can talk about it. So what is the importance? It recognizes lifestyle medicine, and that's what we're going to be using the word here. And I borrowed these slides from my group in lifestyle medicine. It recognizes the link between epidemic and preventable diseases and lifestyle factors, but it's all science-based. We don't talk about things that we can't show literature for. 80% of premature deaths, 80% of all of premature deaths globally are due to lifestyle factors: tobacco, diet, and physical activity. So, hey, 1 in 5 people smoke, 4 in 5 need to improve their diet, 3 out of 4 people do not get enough physical activity. If I tell you if you fix these 3 things, that your risk of cardiovascular disease, diabetes, dying early would drop by 50%, do you think it's worth it? We kind of know this is a problem. 50% of physicians are overweight, by the way. So I'm not saying anything I don't need to work on myself, okay? So I'm just letting you know that this is a serious, we know this, the data is out there. I'm going to present some of that for you. Less than 3% of the population of this country have all 4 lifestyle behaviors. And the NIH is on this, and they completely, this is not something that they refute. Okay? So if we actually focus on this, there's a lot of published data. I will not present it to you, but I will just show you that this is basically what came out of 2012, and it's been endorsed by these different groups. Lifestyle changes and medical therapy should be the mainstay for most patients with stable heart disease, focusing on eliminating all the unhealthy behaviors, period. Okay. What are they? Pretty obvious stuff. There's some that are not so obvious. So this is the point. For this point in this lecture, this is what I'm telling you. You got to turn off the faucet. What we've been doing in medicine has been mopping the floor and leaving the faucet running. Any thoughts on that? I'm a physician too. I'm not saying I do any different. I have a clinic Monday afternoon. The kids come in. It's called an ADHD clinic. I supervise the fellows. The fellow sees the patient. The child comes in. We do a couple of evaluations. We give them stimulants. They go home. Okay? Do I have the time to do lifestyle intervention changes? No. Would it possibly, in a public policy, cost effectiveness ratio, mortality, morbidity, be very important for the healthcare system to carve out that time, also by educating our providers, but also giving physicians the time to possibly do the counseling that we need to do? Okay. So this is what we're trying to do. We're trying to advocate for it. Only 11% of patients with diabetes take their accepted dietary recommendations. 8% of patients with heart disease continue to smoke. So basically, 1/3 of most common cancers in the U.S. can be prevented, common cancers. So forget the other stuff. The 80% of chronic diseases, I said preventable diseases. 1/3, 33%. There's a lot of data out there that we just do those lifestyle changes of those 4 things, 5 things that I mentioned, and actually dig into what they are and make those changes, we could prevent. I'm not mincing words there. Okay, these are some of the key studies. They're very robust. You could definitely go into them. If you want these slides, just email me. I'll be glad to share them with you. So just to kind of give you a sense, I'm not going to be able to go through all the lifestyle changes. How are we doing time? Yeah. I'm not going to be able to go through all, but I just want to touch on one just to show some level of depth on that. So food guidelines started in 1916. We didn't have a sense of where we should be. We started with this wheel. We said everybody should eat margarine and butter every day. Now we would probably balk at that, right? But this is what we believed in the 1940s, the same time that everybody was given a cigarette. Okay, in the 60s and 70s, we went ahead and changed them again. We had bread group, milk group, cereal group, veggie group. We had all these things, and we didn't really have any granularity about what we were, what the percentage of fats, the sugars, the calorie intake. Then we went into the hassle-free. This is when there's two people in the family going out and working. So everything was about quickness. This is when also the processed food industry really took off. Before then, we didn't have much of that in this country. Then we went into 84, into this wheel, where we're trying to understand that we have 5 major groups, and then they started talking about different amounts of calories that you need to include in it. And then this is 1992. This is probably where you guys all started when you were in middle school-ish. But this was the pyramid, and look at this. Would that fly now? Oh my goodness, this is what we were saying. This is just recently, man. We're saying we should all eat 6 to 11 servings of bread. That's required. So if you have a little list and you check it off every day, make sure you get it all in, right? Okay, then we go to 2005 to this, and then this is the first time that they included physical activity. They changed it and they put different calorie levels. Then, up on top up here is what the current FDA recommends in something called the My Plate. This is just to show you where I think it's going, the trajectory in the future. And this is my last slide because I know I'm going to be running out of time. This is what the government currently recommends as of 2011. This is what Harvard has on their website. What are the main differences between what the government's recommending and where Harvard is going with it? Yes?
Do you specify whole grains and healthy proteins?
So whole grains where? Here. So they're not saying so the government is saying grains, Food and Drug Administration, whereas Harvard is saying whole grains, so it's qualifying the grains. And then the proteins, they're saying healthy proteins. So here they're saying proteins, they're saying healthy proteins. If you read this, you're actually saying minimize animal protein. So there's other protein outside of animal protein. What else? There's one other major, yes?
Well, it says no dairy.
And what is that about? What is that about? This is the top part you're going to be throwing into it in a minute, okay? So there's a lot of data about that. I'm not making it up. This is what Harvard's saying. They're asking you to limit milk. Can I ask you something? What other species on this planet drinks other animal milk besides humans? Do we need milk? Where is that started? How much is a normal amount of milk? Why are we taking cow's milk and drinking it? Seriously. That's the question. That's the question. It's a question that I actually never thought about until I took this course, okay? So if you just look at it a little bit and you look at the granularity, dairy, so this is what they say about dairy. My Plate recommends that every meal that they do that, they're suggesting limit dairy. There's a lot of data that's emerging. I'm not saying it's hard science yet, but Harvard seems to think so. There's a lot of information emerging, guys, that dairy causes epigenetic changes in your DNA. This is what the summary is right now in the world. What is this from? I can never remember. Research Federation, World Cancer Research Federation. So they're saying that there's an increase. Okay, so this is another data point. The other thing that's missing here, between the proteins, is they're asking you not to eat processed meat. It has been unrefutably accepted across the world that processed meat has a direct link to cancer as strong as cigarettes. What are processed meats? What are processed meats? Anybody know? Hot dogs. What else?
Bacon.
Bacon. Huh? Things that we feed our babies and children in elementary school. So my question for you. My question for you. If we can believe that it took us 50 plus years to do regulations after we figured out that smoking is directly related to cancer, Who is to argue? Who can tell me that we're not going to be there in 20, 30, 40 years on these topics? There's a lot of data being collected. There's a lot of very important research being done. Keep your eyes and ear open. Think about it. Understand it. There are potentially marketing, advertising forces that are not allowing you to see this data. I am sorry, but I am very happy to report that this is going to be out there. You will see it everywhere between 2 to 3 years. Okay? Thank you. Questions? One question. Yes. Go ahead.
So, what is you've called this like a new field. What would we say is the difference between lifestyle medicine and just preventative care?
So preventative care is basically, preventative care is basically more of a higher, it's not an individual level. So what we're trying to do in lifestyle medicine is work with the primary care physicians and actually work with them and teach them. So we're trying to do it an individual, whereas preventative care is about policy, immunizations, all those big items. Okay?
And then also, I like your faucet metaphor, but it seems that certainly the medical field profits off in some ways their patients being unhealthy. So why?
See, I didn't do the conspiracy theory one, but there you go.
That's it.
So
I was trying to be scientific.
Right, so the question is if you're getting paid a lot to mop up the floor, why would you want the faucet to be turned off?
Because we're not going to be, and I have an answer to that, we are not going to be able to afford the fact that 66% of the world's population is going to have diabetes before 2030 and be overweight. Who is going to pay for all the mopping that has to happen? We are spending so much money cleaning up as opposed to dealing with the etiology and the problems. We can't do this anymore. And I would add another point, which is beyond the scope of this point, but I think AI is really going to play into this at point. So I think we have a value add, me and physicians have a value add as physicians, and with the interspersion of what's going to happen with the robotics and the AI, and they're going to be taking over some of the mundane tasks, we are going to be able to then spend more time with our patients, and we need to have the skills to be able to do it. Does that work? Okay, thank you.